Dr. Chao, thank you so much for being with us today. I'm so happy that we're going to be talking about breast cancer and reconstruction, especially with you.
Well, Jacqueline, thank you for having me on the podcast. As you know, October is Breast Cancer Awareness Month.
Yes, that's why we're wearing our pink.
We both got our pink on to support that. And it's actually quite important because I don't know if you know, but 1 out of 8 American women get the diagnosis of breast cancer.
That's a harrowing number. It really is.
We have gotten very, very good at detection. So we can actually get detection down to a 1 to 2 millimeter size nodule on our mammograms and on our MRIs.
So what that means is we've been more diligent in getting our mammograms, and therefore we're detecting it more often, correct?
Often and earlier, which then gives women a whole lot of opportunity. In fact, the statistics show that in our current state, if you get breast cancer, you have a greater than 95% chance of survival.
Wow. And is that based on detecting it early, or is that just all?
The progress is earlier detection.
Okay.
And so this is one of the cancers that is very beatable.
And to me, what that says is that we don't need to bury our heads in the sand and avoid our mammograms. I know I did for many years just because I was scared. I was scared of getting that diagnosis because it is so common. But what you're saying is get your mammogram, and if you detect it early, we've got a lot of options.
Absolutely. That's what's been the game changer in the last 10 to 15 years is that A, early detection, B, additional modalities or options for women. It's no longer this grin it and bear it, live the rest of your life without a breast.
Okay. Yes, which is why we're talking to you, because you are a reconstructive plastic surgeon, and in addition to that, you're a microsurgeon, which is quite specialized.
Yes. So it is. It's kind of a good portion of my practice is the microsurgical reconstruction.
Okay.
And one of the larger areas that we do the microsurgical reconstruction is in breast reconstruction.
And what does microsurgery mean?
It doesn't mean a little surgeon, because you can see I'm pretty big. What it means...
You're just a tiny little surgeon.
Yes. What it means is that we deal with small blood vessels.
Okay.
Blood vessels that are about the width of a pen stroke, and we use suture that's 1/5 the diameter of your hair underneath a microscope and sew those blood vessels together.
So how are you seeing this?
Well, we use the microscope, so most of the time it's you can't really see it with the naked eye.
Yeah.
So for some of the people in the OR, they think we're sitting underneath the microscope doing what I call air sewing, but we're actually sewing the suture. So it takes a steady hand. Obviously, no caffeine.
Yeah. Oh my gosh. And that's because you're dealing with blood vessels.
Yeah. So the goal here is what advanced the field of plastic surgery and the specialization of microsurgery is being able to take tissue from different parts of the body and disconnect it or cut the blood vessel and then transplant it to another part of the body. And using these microsurgical techniques, you can then go ahead and sew them and keep that tissue alive. So I can now transfer tissue really anywhere within the body.
So if you're cutting out a specific piece of tissue, then how are you reattaching those blood vessels from the ones you cut?
So you find new blood vessels in different areas of your body, and you hook them back up.
Wow.
Right.
And the blood is just fine with that. It just keeps on flowing once you hook it back up.
That's the surgical technique, and that's the understanding of which blood vessels hook up to what kind of pressures you have to have. So that's the art portion, and that's why that's the highly specialized version of that, and not all plastic surgeons do microsurgery. Because
it's an additional couple of years?
It's an additional minimum of a 1 year training in addition to your general surgery, your plastic surgery, and then an additional year of that.
Wow. Okay. And how this applies to breast reconstruction is basically, from what I understand, if one gets the diagnosis, they've got options. And if we're talking about reconstruction, it's going to be prosthetic, which would be an implant, or autologous, which is your own tissue.
In the medical terms, the prosthetic is an implant reconstruction using things that are off the shelf or man-made.
Yeah.
While the autologous, the word auto, meaning yourself, your own tissue. I'm taking tissue from where there's excess that you can spare to areas where you're deficient.
Interesting. Okay, so let's start actually with the autologous, since we're talking about the microsurgery and how that even happens. So if this is the case and someone says, you know what, I want to use my own tissue, first of all, why would they want to?
There are pros and cons of each side.
Yeah.
The value proposition of an autologous or using your own tissue is exactly that. It is your own tissue.
Right.
Once I perform the surgery and the flap taken grows in, it is yours. It's your own flesh. It will act as your own flesh. It will age as your own flesh ages.
Okay.
There's really no other maintenance that is necessary for that because it's grown into you. It's a new part of you.
Got it.
So where we can take the tissue from when we're talking specifically about breast reconstruction are what I call the 3 Bs.
Okay.
The back, the belly, and the buttock.
That's the tissue that we're going to take from to recreate a breast.
Correct.
Or breasts, plural, right?
Yes, if she ends up having a double mastectomy. Correct.
Okay. So assuming that we've got enough tissue, because you'd want enough tissue to be able to do that, then what happens?
Once the woman gets a diagnosis of breast cancer, it's really important to really make sure you have the right team and the teammates on that team. And the teammates that should be on the team are obviously your surgical oncologist. That's the surgeon or doctor that's going to remove your breast cancer, your cancer.
Okay, surgical oncologist takes the cancer out.
Right. The medical oncologist is the person that's going to make sure that doesn't come back with the adjuvant therapy, chemotherapy, or others.
And then follows you afterwards as well.
Right. Third is your reconstructive plastic surgeon. To make you whole again.
Okay, perfect. All right, so if someone gets the diagnosis, would they meet with that team initially or kind of throughout the process?
Actually, the best way is to meet initially, to look at all of your options from all sides.
Okay.
And then what happens is that as you go along your journey for breast reconstruction, you then, one person becomes more influential or dominant during the initial phase, the surgical oncologist. Then the treatment or maintenance phase is throughout with your medical oncologist.
Okay.
And then your plastic surgeon is also in there after the defect is made and the relationship there. So it's really best to get a team started, and then you'll interact with them in different time points at different levels throughout your journey.
So let's say that's the case, and then the woman has the option. Does she want to go the prosthetic route or does she want to go the autologous route? Let's start with autologous, and the reason or the pros, like you said, would be it is your own tissue, and you don't have to replace your own tissue like you would with an implant or the prosthetic route. What are the cons of doing the autologous route?
The cons of the autologous, it's a bigger operation.
Okay.
Takes longer, as we alluded to, the microsurgery, sewing those blood vessels, sometimes takes 3 or 4 hours to do that particular procedure, and sometimes longer, depending on what kind of blood vessels you get. But once it's successful, it lasts a long time. So the recovery is longer, but once you get through that recovery, the results are really everlasting because it is yours. We've transplanted that tissue into its new position, and it'll start behaving like the new position.
Got it. And there's no chance of, let's say, a rupture with an implant or a leak with an implant. Obviously, your own tissue is not going to rupture. It's not going to leak.
Correct. It is yours. It's living tissue. It moves like you and all that.
So what are the different kinds of the autologous reconstructive options? Do I have options within that?
Absolutely, Jacqueline.
Okay.
So if we start with the one in the back, it's called the latissimus dorsi flap.
All right.
Okay, and that's the one that affects some shoulder movement and things like that. So when the people do the lat pull downs that have that big triangular, that's the muscle that you rotate to the front for coverage.
Oh, you take the muscle out?
Yeah, so you would lose some muscle strength, so that's one of the disadvantages of that.
Interesting.
Then you have, then the next most common is the buttock operation. Where you take a piece of your buttock.
Yeah.
What you do is you take some fat, some skin, and sometimes some muscle. Depends on what that is offering and how much you need, and then you can make breasts with that. That tends to be a tougher operation, tougher to recover from because you're cut on the front and you're cut on the back. So how do you recover? You're laying on your backside. It hurts.
Laying on your front side.
It does not, you can't do that.
What do you do?
Yeah, so those are longer recoveries.
Okay.
So that's why they have not been as popular.
I see.
The most popular ones are from the belly.
All right.
Because, like me, I have a little belly here, so we can afford to give that up.
Okay.
Type of deal.
Okay. And so when you take it from the belly, are you taking muscle as well as fat as well as skin?
So again, there are different types of operations or different flaps that you can do for that.
All right.
And predominantly there's two ways that you can do this. The traditional way has been what's called the TRAM flap, T-R-A-M.
All right.
And that stands for transverse rectus abdominis myocutaneous flap, TRAM. You're taking one of the muscles of your abdomen.
Yeah.
So that's why the myocutaneous, myo's muscle.
All right.
And so we all have kind of what we call six-pack abs.
All of us have them, yeah.
Right? So I take one of the six packs and I then take that with the muscle, with the fat and the skin, and I move it to the chest area.
Wow. It's pretty amazing that you can do that.
Yes, and so that's with microsurgical techniques and other techniques. The newer opportunities, we've been able to refine that flap where we can actually leave the muscle behind.
Which is better because then you retain that strength.
Exactly. So I leave your six-pack alone.
Okay.
And I just take the fat and the skin that's above that and move it. So your core strength is not changed.
And so is this one the DIEP flap? And that's DIEP.
Yes.
As opposed to DEEP.
Yeah.
And let's see if I can get it. It's deep, inferior,
epigastric,
perforator. Where's the perforator in it?
So that's what that means is that instead of the muscle, the myocutaneous, you're leaving the muscle behind and just taking that perforating artery or that artery that runs through the muscle and leaving the muscle tissue behind.
So you can take the artery but leave the muscle?
Right.
So is it like pulling a string out of
It's actually
fabric?
It's actually the opposite. Carefully removing the fabric and leaving the string alone, because if you pull on the string, you damage the artery. So it's carefully removed. So it's much more tedious, a greater skill set to do that.
All right.
But the advantages to the patient are significant because you're leaving the musculature behind.
And does that mean also that it is a lesser recovery time since you've left the muscle there?
Yes, so your recovery times are faster with that. So more highly technical, but faster recovery. So
I mean, that sounds so highly specialized, which obviously you are. Would everyone have access to a plastic reconstructive surgeon who is also a microsurgeon, or would they need to travel to get to one?
Most metropolitan centers, or certainly at most of the larger medical schools or medical centers, have that capability built in.
Okay.
What's really happened in the last 5 to 10 years is that we've gotten very good at that. I've personally trained 42 other plastic surgeons. They have those capabilities to move forward with that, and that's becoming more and more popular in private practice to do that. So it is becoming more available. I wouldn't say that this is the standards where in private practice that it's offered all of the time, but certainly in metropolitan cities, New York, San Diego, where I practice at, those are options that are available to women, and they should seek them out and just to see if it's right for them.
Absolutely, just so you know all of your options.
Right.
I mean, it sounds to me like doing either the TRAM or the DIEP is much more involved, takes a lot longer, but again, you don't have to replace it, as opposed to going the prosthetic or implant route.
Correct.
Okay, so let's talk about that one.
Sure.
All right. Why would someone want that?
So why someone would want that is someone that doesn't have the donor sites, so they don't have extra tissue in the back belly or buttock.
I see.
So they can't do that because they just don't have enough tissue
So
to donate.
autologous may not even be an option for
some women.
I see.
Type of deal.
Okay.
And others, they just choose to have a shorter recovery time. They don't want the longer surgeries type of a deal. Or they want to have really both breasts match or improve the look of both breasts.
Oh, which the implant would do more effectively?
Can be more effective about and would certainly be less quicker to recover from and all of that.
Just from a cosmetic perspective, one can get a really great result from the autologous?
One can get a great result from both.
Okay, so back to the prosthetic. Let's say I say, okay, you know what? Yes, I want to go that route. Now what choices do I have?
Well, so if you're going the prosthetic route, there's a number of different choices. And that has to, again, going back to the team.
Yeah.
The surgeon that removes the breast
Yep.
and the surgeon that reconstructs the breast should be on the same page and so talk to each other.
Sure.
So because in today's world, if you work together with some of the early techniques, the detection techniques, and some of the newer cancer removal techniques, you can have what we call immediate or direct to implant reconstruction, which means that in the same setting, before you wake up, you can have your mastectomy, and then you would wake up fully reconstructed.
Oh, one surgery rather than two.
One and done.
Now, that's dependent on early detection?
Uh-huh.
Wow.
Early detection, also working with surgeons, the surgical oncologists and the plastic surgeon working together and devising a unified plan.
That's amazing. Okay, so at the onset, you really want to make sure your team is in place and that your team works well together.
Right.
Is this the norm for teams to kind of, run in these packs?
Yes. So again, recommendation is obviously make sure you look for board certified surgeons, certainly board certified reconstructive or plastic surgeons, and preferably also these breast cancer centers. There are a lot of these women's centers and cancer centers, and those are centers that have the staffing, the correct staffing and armamentarium.
If you go the prosthetic route and you only have breast cancer in one breast, do you treat both breasts so they look the same?
And the answer is that's our goal. The good news in my state in California, there are laws protecting women that allow for bilateral or two-sided surgery, even though you only have cancer in one side. Insurance companies will cover doing the contralateral breast to match and for symmetry. Unfortunately, it's not in all 50 states. It's in about 45 states, so there's a few states that aren't as progressive with that. And again, that's why we have Breast Cancer Awareness Month.
Definitely.
To make sure we get the word out and we understand and empower women.
Most definitely. I think understanding your options is really important because being in a situation, and two of my very best friends in the world are both breast cancer survivors, and so I know just from being with them that when you get that diagnosis, you're reeling. And so then to try and put all of these medical pieces together and comprehend it is so incredibly overwhelming that you may not even be thinking about the cosmetic side. What is this going to look like afterwards because you're so worried about getting the cancer out? So having those, knowing what your options are, I think is really, really important.
Absolutely. So really the whole goal of all this is really to empower and present options. Just like with breast implants, we have a litany of different sizes and shapes. There's more than 52 sizes and shapes to get the right fit with the women.
Okay.
And again, as you mentioned, contralateral surgery.
Yeah.
So there are a lot of my patients that end up with what they call, my breasts look better than what I started with. And that really warms my heart, because they fought a fantastic battle.
Yeah.
They won. They beat breast cancer, and they're living their lives much more fulfilled, and they feel that much more confident.
Yeah. I like knowing that, one, it doesn't have to be a death sentence, and that, two, you don't have to think that your entire self-image is going to change based on your end result.
Absolutely.
Okay.
I always tell my patients, if you have breast cancer, there's something we can help you with. This is not a one and done situation. This is something that you're with me for, at least what I call, we'll definitely share Christmas cards, because no matter whether you see me in December or you see me in January, it's probably a year-long process.
I see.
To get you to your goals.
Okay.
And my goal is to improve that outcome for you.
Okay. So with the prosthetic, I'm going in and I'm getting implants. What is that recovery like compared to if I was to use my own tissue?
So the recovery, as I mentioned earlier, with some of the newer techniques, you can be one and done.
One and done.
So the one and done is really a matter of a week to 2 weeks, and you are pretty much back to activities of daily living. You're still not working out yet and running marathons and things like that, but being able to dress yourself, being able to drive your own car, and function in activities of daily living.
That's pretty amazing.
Taking your children to school.
Okay.
Things like that.
Got it.
If you have something that's a little bit more advanced of a cancer, and you cannot have the latest techniques where they spare your nipple or the skin sparing, then you may have to go through a 2-step process.
Okay.
Where you first have a tissue expander. So it's a balloon, much like a tissue an implant is.
Yeah.
But it's designed to shape the subsequent skin envelope around that.
But it's temporary.
It's temporary. Once it achieves the shape, in terms of the shape or size, then the woman comes back and removes the tissue expander under a separate operation.
I see.
Implant. So I'm having this, so I'm going to go ahead and put a tissue expander in and expand her skin from that side up a little bit.
Yeah.
Right? And then the second step, I'd come back in, take the tissue expander out, put an implant in, and then put another contralateral implant on the other side.
And some people may want to opt for going flat, as one of my guests has gone that direction, and she calls it going flat.
Yes.
Why would someone want to do that?
There are a couple of reasons why. One is that a patient may have more severe disease.
Yeah.
So if there's nodal involvement or something like that.
Lymph nodes, right?
Lymph node involvement. So you may want then to defer any reconstruction till you get everything taken care of and treated and focused on that.
Okay.
And then come back. In those cases, you definitely would then, if you're doing an implant, would definitely have to have a tissue expander, because remember, you're flat.
Right.
And the idea here is we got to shape the skin or the envelope into a breast.
Okay.
Right? And so the tissue expander is then used. And then once the tissue expander has the tissue has been expanded to the right size and shape, you take the expander out and put the implant in.
All right. So let's talk about different implants. You said there were 52 different sizes and shapes.
At least 52.
At least 52. Is it the kind of thing where you walk into a room and they're just, on a big shelf, like you go, and you're looking at shoes and there's a whole wall of shoes? Is it like that? And you're like, oh, I like that one over there. What happens?
In general, what it is that's the choices that you have.
Yeah.
You rarely walk into a room because it just gets too confusing. It's really tools that the surgeon would have. It's sort of like Michelangelo just didn't have one brush to paint the Sistine Chapel.
Right.
He had multiple brushes.
Okay.
We have multiple implants to fit. So what we would do is we would take some measurements like a tailor would, and we also have some 3D imaging. So we have a 3D camera that has 16 cameras and gives you a 3D rendering of you, and we can then also do digital surgery, where we can take different implants and drop them in to show you sizes
Really?
and shapes. So in my
how
practice,
fun.
in my practice at Prime Plastic Surgery and at Oasis, we have those tools to give you the simulation of what that looks like. And again, empowerment and choice.
That's incredible. Digital surgery. I've never heard of that.
It has the implants pre-programmed into it, so you can just kind of just drag and drop and see the sizes.
Oh my God, that is so amazing.
Yeah, so go check out your board-certified plastic surgeon. They should have all these tools to be able to help you.
All right. So obviously you'd be deciding between silicone or saline.
Yes.
And then shape-wise, would it be more round versus
absolutely
pointy? I mean, what are they called?
Right. So in breast implant surgery and reconstruction, implants are not just a certain size, but they have a certain shape and they have a certain fill.
Okay.
So you mentioned the fill. Saline versus silicone. So saline is just filled with water.
Water.
Okay. And silicone is kind of a silicone. Silicone got a bad name back in the 80s because it was made out of a liquid. Now all of them are like gummy bears. They're all basically some kind of cohesive implant, meaning that if they were to break open, it's a jelly material. It's like Jell-O, a gelatin material.
Okay.
So they don't leak out of you. They are fully FDA approved. They've been approved over the last dozen or so years.
Okay.
So rather safe. They've reconfigured them so all of the previous bad press associated with that is really not true anymore. And I would say that 99% of my breast reconstruction patients who end up electing an implant choose a silicone implant.
Okay.
And the reason why is because it just feels like your own tissue, more pliable versus a water balloon.
No microsurgery involved in the implant route, in the prosthetic route.
Correct.
Okay, so you don't necessarily need a microsurgeon to do that.
Correct.
You just need someone who is, you'd want them to be board certified. You want to make sure that this is a specialty.
Correct. So that is something that is trained as a basic part of a plastic surgery residency or training program to get your board certification. And in fact, about 2/3 of all breast reconstruction is actually done with implants. So that is the more popular route. And the reason why is because, as I mentioned, there's lots of sizes and shapes. So you can have, depending on the projection that you want, how much cleavage do you have and things like that. So that's the customization.
Okay, and you can see that all with that digital surgery too.
And you can just see that with the digital surgery as well.
Pretty amazing. Pretty amazing. All right. So my takeaway from this is, in terms of being a reconstructive plastic surgeon, and when we're talking about breasts and breast cancer, since it is Breast Cancer Awareness Month, is to know that there are options. And if you are one of the 1 in 8 women who get a breast cancer diagnosis, it's much better to get it at the beginning so you can maximize those options.
Yes.
Right?
Absolutely.
Yeah. Okay. And 95% survival rate, which is very high compared to other cancers, I would think.
Such as pancreatic cancer.
Okay.
That's less than 50%.
Okay. Why did you decide to become a microsurgeon?
It's a tool. So I can not only build breasts, but I use the same skill set when somebody has jaw cancer, or they have an accident with a gunshot wound, or in one case that I did for charity where there was a young boy that had half of his jaw blown off from a landmine that he had stepped on, type of situation. I can take a leg bone, the fibula, bend it into a C shape, and move it from the leg bone and make a jawbone out of it. So those are So microsurgery is like nails or a screw that you can do and use to build things with.
Okay, that's incredible. How do you bend it though? How do you bend a bone?
Very carefully.
I mean, I didn't even think that bones would bend.
You have to make little microsurgical cuts in it and slowly blend. It's how a boat builder would take a solid piece of wood and bend it into the curve of a hull shape of the hull.
Oh my God,
so
that must take forever.
It takes a while, but 6 or 7 hours surgery.
Wow.
Yeah.
What would you say would be your most complex case you've ever done?
Most complex case is obviously some of the jaw reconstruction, where you also have to do that, plus the floor of the mouth and part of the tongue type of deal.
Yeah.
And obviously some of the transplants that you're hearing about in terms of hand transplants or face transplants.
Ooh, face transplants.
Right, so those are all done by microsurgeons.
Wow.
Yeah.
Back to breast cancer. Have you been in a situation where you've had to give someone that news?
Yeah, in fact, it was just 2 weeks ago, a routine situation where she ended up having came in to see me for a cosmetic operation for her implants, and there was something that was not quite right associated with that, and we found some abnormal cells, and we had to then refer her on. So yes, I work with a couple of surgical oncologists directly and a few medical oncologists. So we were able to get her rallied around very quickly. Literally within the same day, we got her to see the specialist of the team, because as you mentioned, when you get that diagnosis, it's like a freight train hitting you. You just don't know which side is up. And you're in a spin.
Yeah. So what would you say to someone who had just gotten a breast cancer diagnosis, and let's say they were your friend and they were reeling and they just didn't know what to do? What would be your kind of comforting words?
This is a very, very beatable. The odds are greater than 95%.
Yeah, that's great.
Number one. Number two is, I think I'd put them in touch with some of my former patients, because as mentioned, this is a journey.
Yeah.
It's not a one and done. Your life is not over.
My one best friend who's a survivor, she chose to do the one implant but did not do the other. And so she did have to then go and replace that implant. And so that was, like you said, with the autologous, with your own tissue, you don't need to replace. But with implants, you would need to replace them every, 10, 15 years?
Yeah, it just depends on, how fast they quote-unquote wear out. They're not meant to be lasting a lifetime. 15, 20 years is a very reasonable estimate.
So you just, if you go that route, you just need to know that you're going to be, going under surgery again.
Yes. And then you obviously, because you're a breast cancer survivor, you're going to be under heavy surveillance. So you're going to have people, your medical oncology team will be following you.
They'll know when to switch them out.
Right. So through various imaging tests, whether it's mammogram, digital mammography, or MRIs or other stuff, we'll be able to follow that capsule. Obviously, annual exams and things like that.
And what is that surgery like, the switching out?
Oh, it is very straightforward and easy. If the first stages are done properly and correctly, again, with your team, then usually what happens is that you end up just kind of swapping out some minor changes with that, and you're usually recovered within a couple of weeks, and you're ready to go.
The complications, on the complication side of the implant, those complications, could they be infection? Could they be leakage? What's kind of the worst that could happen?
Obviously, worst is really the issues of infection or capsular contracture.
What is that? What is capsular contracture?
Capsular contracture is when your body puts a wall of scar tissue, and that scar tissue becomes so thick or dense. Just think of it as equivalent to an internal keloid. You know how some people, when they have surgery, they get that raised incision on the outside?
Yes.
Well, you're getting surgery and you now have that thickening or that raised tissue on the inside. So the implant can become hard, it can become uncomfortable. So therefore you would then need reoperation to fix that or remove some of that scar tissue or the capsule.
And that would be actually like cutting away the scar tissue.
Exactly, removing the capsule.
But does that take years to kind of build up that scar tissue?
Most of the time it takes years to do that.
All right.
In a few cases, 3, 4, 5% of the time it happens sooner, within a couple of years.
Yeah.
But for the most part, again, 96% of the time, it happens way down the line when your implants wear out. So you go ahead and take the implants out. pull the capsule, the scar tissue, and start all over again.
Okay. Let's talk about picking a surgeon. On the reconstructive surgeon side, does someone get to pick that surgeon, or because it would be covered by insurance, would it just be assigned?
It really a lot of times dictates is on kind of what kind of insurance you have.
Okay.
Even if you have an HMO, you do have choice. So again, going back, this is an event of empowerment.
Yeah.
The goal here and why we have Breast Cancer Awareness Month is to get this information out.
Yeah.
Women have choice even if they're locked into a certain system. Ask to see results. Ask to see the board certification.
Yeah.
How many have you done?
Okay.
Educate yourself. Know your surgeon. Because, like I said before, you will be with that reconstructive surgeon for approximately a year. So you should really like your surgeon.
You should like your surgeon.
Yes.
And if someone, came to you and asked you, can I see your board certification? That would be asking, like, please present me with a piece of paper?
That is actually on the American Board of Plastic Surgery website. You type my name in.
Okay.
You can go to the American Society of Plastic Surgeons, which is one of our national societies, type my name in, and they'll see if I'm a member and if I have board certified. When that certification is up, also you can go to your state medical board and type in your surgeon's name.
Also a website.
A website.
All right,
exactly.
State medical board.
.gov, most likely. They're governmental boards. So wherever you're licensed to practice, so it's California, it would be californiamedicalboard.gov. You can look up that surgeon's credentials, which hospitals he had, and where did he do his medical school, when and where was he board certified,
right,
and all of that.
Right. It's something that I've heard about from a couple people who have had breast cancer, is that they felt like their reconstructive surgeon, they kind of inherited them, that they didn't really have choice in that because so much of it was about, let's get this cancer out. And then it was almost like an afterthought of, we'll make sure that you've got breasts at the end.
Correct. So that's quickly changing.
Okay.
Because of what you're doing, Jacqueline, educating, getting the word out, and empowering women to say, you do have a choice. Please ask those questions.
Sure.
Please speak up.
Yeah.
This is your body.
Yeah.
This is your right, especially in California where I practice. Breast reconstruction is considered a right. It's not a privilege.
Okay.
And I was treated such.
Yeah, and the reason why, I really wanted to do this show was because knowing my two best friends and having seen their breasts pre and post, I know they feel so happy to be alive, but I do know that going through that process, there wasn't a lot of focus on the outcome. It wasn't ever seen like, hey, I could get new breasts out of this. Right. And that was never the case. It was just kind of like, I'll be lucky to live, and if we get this out, thank God, and I'll take whatever I can get. And what I'm hoping is that women have more knowledge and basically the wherewithal to ask questions. Yeah. Do I have a choice? If not you, who do I get to choose from? This is my insurance. How many choices do I have? Yeah,
obviously within realistic expectations.
Sure.
Absolutely, but I think you hit the nail on the head. It's the issue of empowerment, again, and the issue of, getting into a support group. That is so important.
Okay.
As I mentioned, one of the things that you asked me, if this was a family friend of mine, right? What would I do and things like that.
Yeah.
First things, obviously, tell them that this is a survivable situation.
Okay.
Number one. So let's get that off the table.
Right.
And not that worry, unburden that from you.
Absolutely.
One. Two, get you hooked up with someone who's been through this.
Yeah.
And whether it's a month or 2 months ahead of you, learn from them.
Sure.
And so that's what I try to do in my practice. Any given time, I have women throughout different stages of their reconstruction, and to put them together, or get to your local breast cancer support group.
Definitely.
With that. So the American Cancer Society has done a good job. The American Breast Society, they've done fantastic jobs.
Yeah.
And the fact that, so many athletes are wearing pink this month, and we're doing what we're doing, getting that word out. You're not alone.
Yeah.
So find comfort in someone who's been through this ahead of you to help you, guide you, so that it doesn't become what I call a whirlwind of, I'm not sure.
Yeah, that not knowing is not a fun place to live, most definitely. Right. So having more knowns just on the cosmetic side, I think is an unburdening. And so that's definitely why I'm so happy that you're here to demystify that a little bit. How can we learn more about you? Would that be Prime Plastic Surgery?
Yeah, so I head up 2 organizations. So primeplasticsurgery.com is the cosmetic side, and Oasis MD is the other side, oasismd.com.
Okay, perfect. So those are the 2 places.
Yes.
All right. Well, I'm thrilled to get this overall concept from someone as trained, as completely highly trained as you are. And so thank you for taking time out of your incredibly busy schedule.
Well, Jacqueline, again, thank you for the opportunity, and thank you for shining some light on this and bringing this information out to women and leading in that role.